If we compare AMH and antral follicle count now, if you look at various tests, both of them show significant correlation to age, anti-Mullerian hormone and antral follicle count, as opposed to FSH and inhibin B. They both have a good, strong correlation and they decline with age. This, looking at our own data, also shows a good correlation between the two tests, so they can be used either or both. One of them can be used to predict the ovarian response. Here we see the curve as far as sensitivity and specificity is concerned. Both are almost very similar in predicting the poor ovarian response. But AMH has a distinct edge over antral follicle count if we are going to use it as a tool to predict the ovarian response over a period of time. If you are monitoring a woman's ovarian reserve over a period of time, AMH is the only test which shows a significant decline early on in a woman's age compared to all other hormones, that is all other parameters including antral follicle count, FSH, inhibin B or E2. Whereas most of them in older women are very good of predicting poor response. At a very young age, AMH has an edge over the others. This has led to the development of nomograms for AMH in various populations, where when we know the age of the woman and the AMH value, we can plot it on this graph to see where the ovarian reserve is at a given point of time. And we have these nomograms available for US and European population from the age of 21 onwards. And this helps to chart the ovarian reserve of a woman and maintaining a progressive graph in those who wish to postpone pregnancy may indicate when early intervention is necessary. As far as predicting the other extreme of the response, that is ovarian hyperstimulation, is concerned, IVF is generally a safe treatment, as we all agree, except for the occurrence of ovarian hyperstimulation syndrome. And for preventive strategies to be developed, good predictive tools are very essential. And once again, AMH and AFC are very good predictors of excessive response with a high specificity and sensitivity, as I mentioned earlier. Now, how do we incorporate these information in the scenario of controlled ovarian stimulation? So when we are dealing with normal responders, meaning those who are having an antral follicle count of 8 to 16 and an AMH level of 1.26 to 2.8. Now this upper limit is arguable because there has been no international standardization as far as AMH is concerned, because in the initial years of using AMH, two different assays were used, one coming from DSL and the other from Beckman-Coulter, and the values did not match. And now only in the recent years, all the units all over the world are using the Gen 2 Beckman-Coulter. So hopefully there will be a standardization. And more appropriately, the upper limit for normal response probably would be set at 3.6 nanograms per ml. And in these women, use of your long agonist protocol with standard dose of FSH for stimulation would be ideal. As we see from this study from Glasgow, using GnRH analog long protocol with standard dose of FSH at 225 international units per day gives an optimal oocyte yield with a very low risk of poor response and a very low risk of moderate to severe hyperstimulation syndrome with an expected pregnancy rate of around 30%. Whereas in those who are supposed to be hyper responders, as predicted by an AMH value of over 3.6 nanograms and antral follicle count beyond 16, antagonist protocol with lower dose of FSH would be ideal. Again, the same group did show that when compared to long GnRH analog protocol and FSH, lower dose FSH 150 units as a starting dose, and GnRH antagonist with FSH 150 units, even though the number of oocytes retrieved were significantly less, there was no incidence of severe OHSs, and a better pregnancy was achieved to the tune of 61% as opposed to 31.8%. They also concluded that an AMH level of more than 4.2 was associated with the highest incidence of severe OHSs. Now, when we look at the other extreme response, that is poor ovarian reserve, what is generally believed is that once the ovarian follicular pool reaches the size of 25,000 follicles, there is an accelerated decline in the ovarian reserve. This has been recently questioned because until very recently it was believed that only when a woman reaches the age of 37 and above, there is an associated decline in the quality of the oocytes. But there is some preliminary reports from the animal data which shows that actually when the follicular pool reduces to 25,000, actually it may be associated with a decline in the quality itself. So the last word regarding this has not been said yet, but we know that when the follicular pool comes down to 25,000, there is a decline in the ovarian response. And why it is significant is that a woman with such a follicular pool still has approximately 3 to 4 years to achieve a pregnancy with her own eggs. So the diagnosis of poor response, poor ovarian reserve at this stage is very crucial to achieve a pregnancy with one's own eggs. A cutoff level of 1.26 nanogram per ml of AMH predicts poor response, that is 4 or less number of eggs with more than 90% specificity, and a value of less than 0.5 nanogram per ml predicts very poor response, that is 0 to 1 oocytes in such women, and counseling strongly is recommended in this subgroup of women regarding cancellation of the cycle. So the values between 0.5 and 1.26 nanogram per ml indicates that fertility still remains even though at a lower level in such women. Hence, if appropriate treatment is given at this stage, a woman can still achieve a pregnancy with her own eggs. So we can define poor responders as those who are having an AMH level of less than 1.26 nanogram per ml and AFC of less than 8. But what is very important to note at this stage, as I mentioned earlier, all these tests are very good at predicting the response, quantitative response to controlled ovarian stimulation. But we are not at a stage where we can exclude a woman by telling her that you are not going to respond to treatment at all and don't go ahead with the first cycle of IVF. We have not reached that stage as yet. What should we do in this subgroup of women who are diagnosed to be poor responders? If we use long downregulation protocol with high doses of FSH, these women require higher doses of FSH without any increase in the oocyte yield or pregnancy outcome. So usually short agonist or antagonist protocol with maximal stimulation are the ones which are mostly used in this group of women. And a meta-analysis shows that both of them yield very similar pregnancy outcome, whether we use a short flare-up protocol or antagonist protocol in this group of women. So I would like to conclude by saying that prediction of ovarian response improves both efficacy and safety of the treatment. Anti-Mullerian hormone and antral follicle count help us to identify poor, normal, and excessive responders. Anti-Mullerian hormone and antral follicle count offer reliable means to choose a patient-specific protocol for ovarian stimulation. Of the two markers, AMH is not fraught with intra and intercycle and inter-observer variation. AMH is the earliest marker to show age-related changes to ovarian response. And going through a cycle of IVF and experiencing either a poor response or OHSS is traumatic. And if this can be prevented by being able to predict the response, it will help to counsel such women prior to first cycle. And also we can offer the most suitable GnRH analog protocol and adjust the dose of the stimulant. I just would like to end this talk with a very personal note about Mandakini Pariha. It was indeed during one of Gautam's conference 11 years ago exactly. I met her in Goa. She just walked into my life. Gautam inadvertently brought her into my life. We became very good friends. It was one of the most poignant relationship and friendship I experienced in my life. And as you're all, I'm very, very saddened by her demise. I anyway would like to thank Gautam for introducing her to me, and thanks to you all.